Recording in progress.
Very good evening, all the doctors. Thank you for joining us in. This is the series of Basics in Neurosciences organized by Park Clinic and DG Neuro. So I welcome you for the episode 4, Blood-Brain Barrier and ICP, Understanding the Basics. This is a digital initiative, DG Neuro by Health and Youth Therapeutics, a joint venture with New Link Company Limited, Japan. We have a YouTube channel where you can see all the webinars. We have more than 60 webinars now. You can see the current webinar also tomorrow when we upload it. In epilepsy management, we have Brinda, Rivaroxaban, 25, 50, 75, 100. We have Adclobas, Clobazam, and we launched 2.5 milligram strength for the first time in India. Adclobas 2.5, 5, 10 in mouth dissolving tablet. In headache and migraine management, we have Amnurite, Amitriptyline plus Mecobalamin. We were the first one to launch this. Brentamine, a vitamin therapy for migraine. Again, we were the first one to launch this. Riboflavin 200, magnesium 200, and CoQ10. Amnurite beta, Amitriptyline and propranolol. Again, we were the first one to launch this combination, beat headache together. And NDRAP, 500 and 250, naproxen plus domperidone in a rapid-acting particle form. In neuropathy management, we have Amnurite P, Amitriptyline plus pregabalin combination in a sustained release form, Neurite injection imported from Japan, Mecobalamin injection, and Neurite D. The only beta-histine mesylate available in India now is Basilate, 6 milligram and 12 milligram, because less is more, 25% less dosage. I have great pleasure in also introducing Neurite Active, stroke and post-stroke management, and Backride, the smallest baclofen tablet in India. Now, I would like to introduce Dr. Kaushik Seal, assistant professor, associate professor, and HOD of KPC Medical College, neurosurgeon in Park Clinic, Kolkata, and faculty in Park Neurosciences. Over to you, Dr. Kaushik Seal, please.
Good evening, everybody, and it is an honor and pleasure to invite all of you to this very important discussion, today's discussion on blood-brain barrier and ICP. We have a very distinguished speaker amongst us, who is Professor Anthony Figazi. He is from Cape Town, South Africa, and he is the current head of Pediatric Neurosurgery unit and also the head of Neurocritical Care Unit at the Red Cross War Memorial Children's Hospital in South Africa. He is also in the editorial board of ISPN Guide and the Child's Nervous System, and also the scientific chair of the Neurosurgical Society of Africa. Welcome, sir, on board. Thank you for being with us today. And with him, we have 3 distinguished panelists today. The chief panelist is Professor Sandeep Chatterjee, head of Park Neuroscience Service and secretary of the Park Clinic. And he is also the current president of the Indian Society of Pediatric Neurosurgery. And also he is also in the editorial boards of the Child Nervous System. Along with him, the co-panelist, Dr. Gopalachari. Dr. Gopalachari is a distinguished practicing neurosurgeon in Kolkata and also attached to Park Clinic. We also have amongst us Dr. Amitabh Das, who is a very prolific neurosurgeon and a prolific teacher, also working at Park Clinic. So with this, I invite Professor Chatterjee to give a basic introduction and start today's show.
So I think you've already introduced Professor Anthony Figazi to the audience. I just love one of the Facebook quotes I read about him some time ago, and I remembered it, and I managed to search it up today. And I'll just quote from that quote. It said, if you asked a young Anthony Figazi what he wanted to do when he grew up, it's very unlikely he would have said pediatric neurosurgery. Instead, he says he dreamed of becoming a break dancer, or a gymnast, or a trapeze artist, or a professional athlete, or even a musician. But what must have been a loss for the big top in the world's dance floors was pediatric neurosurgery's gain. So this was how one of his colleagues described him in one of the sessions, and I picked this up from one of the Facebook posts, and I thought this was so apt, because Tony, as we know him, is a man of many, many parts. And what you have not said about him is that he's currently the most important man in the International Society of Pediatric Neurosurgery, being the secretary. And as you know, the secretary is the important person. Everybody else is secondary to the secretary. And Tony is a wonderful person, and somebody I know for years and years, a very close friend. And above all, he's done fantastic and seminal work in neurocritical care and intraoperative neuromonitoring, which are his two babies, if you like. And he's done a lot of work on neuromonitoring. I just cannot forget the article that he wrote about how a child's brain and a child's head injury is different from an adult brain and an adult head injury, amongst the very large number of articles that he's written. But I don't want to introduce him any more than just to say that it's fantastic, Tony, to have you on board. Thank you very much for sparing your time to be with us. And I'm sorry to pester you and to give you short notice and get you up on this. So thank you very much. And I'm not going to say any more and let Tony hold the floor.
Thanks very much, Sandeep and Kaushik. So, that was quite right. When I was 15, I had an offer to join the Boswell-Wilkie Circus, and I was very keen on running away with the circus. And unfortunately, my mother put an end to that. She said, "Over her dead body." So yeah, I could have been in the circus, and at least I've got a job now. I don't think there are too many people in the circus who've got a job at the moment in COVID-19. So I think it all worked out reasonably well. So I'm going to talk. Thank you first for the great invitation. I wish as always, I wish I could have joined you. I've been to India so many times, and I always have a thoroughly enjoyable time when I get there. And there's so many parts of India that I haven't seen yet. I hope at some point this pandemic is going to subside or come to an end, and we can regain our kind of physical friendships with each other. So thank you for the invitation. I'm going to speak, if I may, I'm going to speak much more on the intracranial pressure side, A, because I completely forgot about the blood-brain barrier aspects, but B, because there's just such a lot to talk about intracranial pressure itself, and so much to talk about blood-brain barrier, and I'd really like to talk about the blood-brain barrier separately. And we've got some really, really interesting data, because we're starting to look at pharmacokinetics. And one of the things that I've realized in the last couple of years is have such an intimate relationship with the brain. We have a huge amount to offer in terms of the understanding about how the blood-brain barrier works, and in particular, how drugs get across the blood-brain barrier. Because we have tools in our arsenals that our medical colleagues and definitely our pharmacological colleagues don't have. And they have access only to blood samples and to sporadic spinal CSF samples. And those really aren't good enough, in my opinion, to really study how drugs get into the brain and also the effects that they have. So that really is just a massive subject. And we're doing a bit of work on neuropharmacokinetics using microdialysis as a tool and some other tools. And I'd be very keen if you'd invite me back to speak more specifically about that. So I'm going to talk a little bit about intracranial pressure and the complexities of intracranial pressure, and things that we know and the things that we don't know. So can everyone see my screen?
Perfect.
Okay, fantastic. All right, so when we talk about intracranial pressure, very often it's either in the context of hydrocephalus or traumatic brain injury. And I want to start with traumatic brain injury because it has because we have guidelines for traumatic brain injury and how to manage intracranial pressure. And so that's probably the one condition that A, is very common, and B, we've most acutely or most targetedly focused our minds on issue of intracranial pressure and how to manage it. So we have guidelines, and these are international guidelines on what is an intracranial pressure threshold and how to treat them. So this is from the Brain Trauma Foundation guideline. The evidence isn't strong, but this is the current guideline that one treats intracranial pressure above 22 millimeters of mercury. So there's a slight adjustment between the third and the fourth set of these guidelines. And the evidence for indications for ICP monitors for the exact threshold that we use, as well as what treatment we use, are not great, but they're greater in traumatic brain injury than any other condition. So I thought this was a useful place to start. But for me, and this is a very individual response to it, I think this is far too basic. And for the rest of the talk, I'm going to try to focus on exactly why this is far too basic in terms of our understanding about the dynamics of intracranial pressure and how we should be responding to intracranial pressure, whether the condition is traumatic brain injury, hydrocephalus, or one of the many other conditions that are associated with increased intracranial pressure. So it's a little bit more complicated than thinking about intracranial pressure as just a simple number. And to start, I want to go all the way back to our knowledge about neuroscience actually started with traumatic brain injury, and in fact the recognition that the skull is a rigid compartment, and there are no ways out of the skull outside of the foramen magnum. And so these are skulls from ancient Peru. So this is 3,000 to 4,000 years ago, and these are healed craniectomy wounds. And with the idea that, and this is probably practiced on people who had either epilepsy or some severe neuropsychiatric disorder. And the idea was that they were possessed by evil spirits, probably, and that the holes that were made in the cranium was some attempt to release these evil spirits and try to treat the patients. And clearly, our surgical techniques began very well because these were patients who had a craniectomy. And look at this is over the midline. But who clearly survived it, and this is evidence of kind of healing of the craniectomy. So many of them, we don't know how many of them didn't survive it, but some of them at least survived it. But it was a clear recognition that the problem that we have with the brain is that the cranium is a solid compartment, and so the critical principle is really the balance between pressure and volume. And so everybody knows the pressure volume curve. And it looks very flat in the beginning. So the brain has a huge amount of compliance. So as you increase in volume, whether that volume is increasing in CSF or brain water or blood or tumor or some other pathology that takes up volume, the brain will try to compensate for that. And it compensates for it reasonably well, depending on how quickly that volume increases, by squeezing out excess CSF and excess venous blood. So that's why the first part of the pressure volume curve is very flat. But then, as we know, we get to a point where the compensatory mechanisms of the brain are exhausted. And then any addition of volume there increases intracranial pressure quite rapidly. So at the flat part of the curve, you can increase an increase in volume with very little change in pressure. But then that same increased volume, when you have lost compliance completely, on the right side of the curve, can lead to quite a dramatic increase in intracranial pressure. And so that's why we have the problems that we have with intracranial pressure. And there are two main problems. And one of them is shift. So when you have an increase in intracranial pressure, particularly if it's compartmental, you can have a shift from left to right, subfalcine herniation. You can have a shift from the supratentorial to the infratentorial space, the transtentorial herniation, or the dramatic shift across the foramen magnum. And it's called coning because literally it looks like a cone. At post-mortem, the tonsils of the cerebellum and the vermis of the cerebellum are squeezed through the foramen magnum. The foramen magnum is only 3 to 4 centimeters in diameter. So the lower part of the brainstem, the medulla, is pushed up against the anterior rim of the foramen magnum. It occludes the respiratory center, and patients have apnea, and they have a cardiovascular collapse, and it's a dramatic end to life. And that's what we all fear as neurosurgeons, the dreaded coning. And then, of course, you have other complications like transentoral herniation, typically because the posterior cerebral arteries run in the ambient systems along the tentorial hiatus. They get kinked, and you have posterior cerebral artery infarct. So these are the typical problems that we see with brain shift. And I've always marveled at why we don't think of it as a compartment syndrome. So this was an article we wrote about 15 years ago, where we first described it as a compartment syndrome. This was about decompressive craniectomy, but it fascinated me that the orthopedic surgeons talk about compartment syndrome all the time. And you, as surgeons, you will know about compartment syndrome because it's usually in the context of a crushed leg or limb, or sometimes in the abdomen as well. And the principle is you've got a relatively inflexible compartment. It's a myofascial compartment, and you have trauma to that. The muscle swells. It swells to pressure that's higher than venous pressure. So venous drainage stops, and therefore you have arterial inflow but no venous drainage. So that increases the pressure more. It becomes a vicious cycle. The pressure becomes even greater in the myofascial compartment to the point where the arterial inflow then gets blocked. You have ischemic tissue and neurogenic dysfunction. So that's the typical compartment syndrome, and the treatment of that is a fasciotomy. And of course, we just haven't been considering it in the same way in neurosurgery, because the skull is the compartment syndrome par excellence. It's completely rigid. It doesn't give. And when you have a volume that's increased to the point of obstructing venous return and then arterial inflow, you have all the symptoms and signs of a compartment syndrome, but much worse because it involves the brain. So brain shift is the first major complication, and then brain ischemia is the second one. So the perfusion pressure, which is the effective pressure of blood pressure getting into the brain, depends on mean arterial pressure, which is the average of pressure generated by the heart and the great vessels to get blood into the cranium, and it's resisted by intracranial pressure. So very simply, the functional perfusion pressure is the difference between mean arterial pressure minus intracranial pressure, which is the pressure resisting the blood inflow. And very simplistically, when you monitor perfusion to the brain, you see this all the time. As intracranial pressure is high, cerebral blood flow and brain oxygenation take a dip. As intracranial pressure comes down, cerebral blood flow goes up, perfusion of the brain goes up. And they have this reciprocal relationship. And so that's quite simple. It's quite a simple concept. Blood pressure getting blood or perfusion into the brain being resisted by intracranial pressure. The problem is it's a little bit more complicated than that. So firstly, intracranial pressure is not just one thing. And there are many different aspects of intracranial pressure, or the interpretation of intracranial pressure. So one is the way that intracranial pressure works in physiology is very different from how it works in pathology. And in pathology, it's very condition specific. And we'll talk about the different conditions and the implications and as for intracranial pressure. It depends on compliance of the brain, as I spoke about with regard to the pressure volume curve. So it depends on where you are on that pressure volume curve and how much compliance the cranium has. The effects of intracranial pressure depend on the underlying metabolic need, and also other limitations to perfusion, again, that may be condition specific. So there are many conditions, and because you have many conditions, you also have many manifestations of intracranial pressure. So the way that intracranial pressure manifests and its impact is quite different in traumatic brain injury compared to the other conditions. Hydrocephalus is quite different, and in hydrocephalus, the way that intracranial pressure plays out is quite different if the cause of the hydrocephalus is acute. So if you have a posterior fossa hematoma, it blocks the aqueduct, blocks the fourth ventricle, and you have acute hydrocephalus. Intracranial pressure is one thing, but in chronic or so-called compensated hydrocephalus or long-standing overt ventriculomegaly or normal pressure hydrocephalus, intracranial pressure behaves completely differently. Also behaves differently in meningitis and infection-induced mass volumes inside the brain, abscesses, and tumors inside the brain, intracranial cysts, hemorrhage. Pseudotumor cerebri is a completely different condition where patients often can have pressures that are incredibly high, 30, 40, 50 millimeters of mercury, and can be sitting there talking to you. Venous hypertension, the intracranial pressure dynamics are different, metabolic encephalopathies, they're all different. Intracranial pressure is a consistent characteristic of all these conditions, but the way that it manifests and the impact that it has and the consequences that it has are all different. So those consequences depend on the underlying condition and depends on the rate of the accumulation of volume. So patients may be completely normal with very high intracranial pressure. They may have the triad of headache and vomiting and reduced level of consciousness. They may have acute herniation. Those are the characteristics of that acute rise in intracranial pressure that you will see with acute hydrocephalus or with traumatic brain injury. But they may present very differently with venous hypertension or long-standing hydrocephalus or pseudotumor cerebri. They may be completely fine, they have no headache, but progressively lose vision. They may have a slow deterioration in function. They may have slowly deteriorating cognition, like you may have in normal pressure hydrocephalus. So common to all these conditions is still intracranial pressure. But I hope you can appreciate that the way that intracranial pressure plays out in all of these conditions is very, very variable. So let's just start with traumatic brain injury. So we know that our best opportunity to alter clinical outcome is to prevent secondary injury. But secondary injury is a little bit complicated. So raised intracranial pressure is a core aspect of secondary injury in traumatic brain injury. And it's both the origin of many of the problems that we have in secondary brain injury, and it's also the consequence of many of the problems that we have in secondary brain injury. So we know that infection, meningitis from a basal skull fracture, for instance, causes secondary injury, but it can also cause raised intracranial pressure. Similarly with seizures and brain ischemia, all the problems that we run into with systemic disturbances, hypertension, hypoxia, hypo and hyperglycemia, hypo and hyponatremia have implications both for the brain directly, but also indirectly through raised intracranial pressure. And then there are many things that we do trying to treat patients. The way that we manage them with hypo or hypercarbia, the intracranial pressure devices that we put in, the way that we manage their blood pressure. Sometimes we get it too high, sometimes we get it too low. All of those may potentially injure the brain, but they also have an indirect effect often of intracranial pressure. So you end up having this development of a vicious cycle. Intracranial pressure gives rise to trouble. It gives rise to seizures. It gives rise to brain ischemia because brain ischemia causes cellular swelling that makes the intracranial pressure worse. So you develop these constant vicious cycles, and intracranial pressure very often is at the heart of it. And then, as I think Sandeep was alluding to, we just have to keep in mind that a lot of the things that we know about intracranial pressure pertains to adult patients. But very often extrapolating data from adults to children is just really not a good idea for lots of different reasons. And I'll just skip through a couple of them. One is that children are anatomically completely different to adults, and they're often completely different to themselves. So a 2-year-old is very different anatomically and physiologically to a 6-year-old. It's very different to a 12-year-old. And then physiologically, they're unbelievably different. You're not treating one population, you're treating a changing population. So I've just got a couple of examples here of how cardiac output and cardiac index and cerebral blood flow change so dramatically within that first decade that truly you're not treating the same population. And this is just a great graph to show that it's not just the absolute physiological changes, but the relative physiological changes. So how they respond to events is very different depending on your age. So this is this graph right here at the bottom from this paper by Moses et al. This is the average cerebral blood flow change in response to a task. And this was a very simple task. It was a finger tap task based on functional MRI. So this was the change in adults. This was the change in 12-year-olds, and this was the change in 8-year-olds. So you can see the functional change in cerebral blood flow in response to a very, very simple task, just a finger tap test. How different it is between an adult, a 12-year-old child, and an 8-year-old child. So it's not just that their baselines are different, how they functionally change to any kind of stimulus, whether they're stimulating themselves, as in doing a finger tap test, or we're stimulating them by suctioning or any of the other procedures that we do. They are profoundly, profoundly different. And then they have different disease patterns. This is just an example in traumatic brain injury. A traumatic brain injury radiologically, pathologically, looks completely different from how it looks in adults. But ultimately, this is what we're trying to avoid. We're trying to avoid a full brain, a swollen brain, and that's now ischemic because the perfusion pressure has dropped below the requirement, which is around about 18 to 20 moles per 100 grams per minute. So normal perfusion to the brain, and this is an average of gray and white matter, should be above 50 moles per 100 grams per minute. And as that starts to drop, you become more and more oligemic, but the brain compensates for that by increasing oxygen extraction. But like the pressure volume curve, there are limits to the brain's ability to adapt. So it increases oxygen extraction until the point where it gets to about 18 to 20 moles per 100 grams per minute. And the brain can't maintain normal metabolism. So anaerobic metabolism starts to increase, and you have progressive cellular failure, inability to maintain cell structure lysis, the conversion from aerobic metabolism to anaerobic metabolism, the increase in lactate, the increase in glutamate, and eventually cell death. And so that's the typical arc of what we want to avoid, and whether it develops into local or global infarction depends not only on the depth of ischemia, but how long the brain is held at that ischemic level. So again, let's start simply. This is what we anticipate. High intracranial pressure reduces perfusion to the brain. And this is when you see cerebral blood flow in these graphs. This is from a program called ICM Plus, which I'll talk about a little bit later. Intracranial pressure is being monitored by normal Icp monitors. Cerebral blood flow, if you see it, it was measured by a catheter called Hemidex, which is a thermodiffuser method that, if you've got some questions about it, I'll tell you about it a little bit later, but it's local cerebral blood flow. And then brain oxygenation from a typical Lycox catheter. So that's the simple problem. The problem is even in intracranial pressure, so just taking one condition, there are several different causes of increased intracranial pressure. So depends on whether it's a hematomal, hydrocephalus, or contusions, brain edema, hyperemia, CO2-related, impaired autoregulation, subclinical seizures, spreading depolarizations. All of these can cause an increase in intracranial pressure. The implications of that intracranial pressure are very often different depending on that cause. And so they all have different implications for perfusions. And I want to show you some examples of that. So it's not just the difference in the cause of the rise in intracranial pressure, also its consequences are determined by the underlying cause. Say if it's hyperemia versus seizures, the consequences are different. And it also depends on the underlying physiological dynamics. So it depends on the metabolic need of the brain, for instance. Very high metabolism versus very low metabolism. Well-perfused brain versus a poorly perfused brain. They all are important in determining the consequences of increased intracranial pressure. So how does all this multimodal monitoring that we've ended up becoming reasonably well known for, how does that help us? And so I'm going to talk a little bit about our experience and go a little bit off track, or at least off the beaten track in terms of the evidence that we have, and trying to merge the evidence with our clinical experience. So we've got quite a bit of experience in children with intracranial pressure and brain oxygenation, with microdialysis for brain chemistry, continuous EEG, transcranial Doppler, hemodynamics, the cerebral blood flow catheter I was talking about, and ICM Plus, which is the software that we use to collect the data. And so first I wanted to start with the software. So we use something called ICM Plus. It's software that was developed by some colleagues of ours in the Division of Neurosurgery at Cambridge University. They are physicists. They developed the program in the mid-90s, and they've been refining it ever since. And it's a great program if you can get it. It collects data, high-frequency data, so anywhere between 50 or 100 hertz. So it's really, really fine data collection. And so this is what it looks like. You can get intracranial pressure like this, but because we're collecting it at 50 hertz, it's 50 data points a second. So you get very fine waveform analysis as well. So whether you want to do waveform analysis or whether you just want to look at absolute or relative changes in intracranial pressure, you can do it with the program. And then you can put in all your physiological variables. So typically we would be monitoring intracranial pressure and brain oxygenation, brain temperature, end tidal CO2. And then this is a way of, you can look at it over several hours, or you can focus in on shorter time periods. So now we're going from hours to minutes, and you can see as you're narrowing it down, you start seeing different relationships. And also when you look at the different range, so yeah, I think I'll change intracranial pressure. So you're looking at a different range of intracranial pressure. Then suddenly you start seeing different relationships emerge between intracranial pressure and brain oxygenation or mean arterial pressure. So it really is a superb piece of software that helps you at the bedside get an understanding not only of the dynamics of one particular variable, like intracranial pressure, but how that variable relates to all the other intracranial pressure, at least intracranial variables or systemic physiological variables that may influence intracranial pressure or perfusion. So I've learned a couple of things that I want to make a couple of points. So this is a really important point, that patients are individuals, not averages. And when we read randomized controlled trials, very often for the physicians, it's a choice between two interventions, a blue pill and a red pill. And very often the outcome of the study will tell you that on average, this is what happens when you take a blue pill. This is what happens when you take a red pill. The problem is the patients that we treat are not averages, they're individuals. And so we've learned that interventions can have variable effects on intracranial pressure in different patients. So I want to give you a couple of examples. One is about CO2 and the relationship between CO2 and intracranial pressure. Now, they have a really important relationship with each other, and it's largely governed by CO2 reactivity. And the relationship between CO2 and intracranial pressure also has both indirect and direct effects on perfusion. And I want to illustrate that for you. So when you look on ICM Plus, you'll often see these waves of CO2 that relate maybe to the ventilator parameters or the way that the patient is breathing. And you'll see common patterns in intracranial pressure that are associated with CO2, because CO2 has a potent effect on vascular diameter. So CO2 reactivity, it changes vascular diameter at the level of the arterioles, and therefore that influences cerebral blood flow, but also very importantly, cerebral blood volume, and therefore intracranial pressure. I think it's particularly important in children because children, in my experience, are exquisitely sensitive to changes in CO2. And for me, most people focus on absolute values of CO2. And I'm not too shaken by absolute values, because the brain has compensatory mechanisms and will adapt to a new CO2. So if you leave it for several hours, the cerebral blood flow will adapt to a change in CO2. The problem is it doesn't do that acutely. So it doesn't manage acute changes in CO2 very well at all. So for me, I'm much more focused on relative changes in CO2 than absolute values of CO2, and I'll show you why. So this was a study that we did that we in fact haven't published yet, although we did it quite a while ago. We looked at the percentage change of intracranial pressure, cerebral blood flow, and brain oxygenation from baseline. So the red line is baseline. When you decrease or you increase CO2. So we decreased the CO2 and we controlled for a change in the blood gases before and after, blood pressure before and after. And we looked at what change in intracranial pressure, cerebral blood flow, and brain oxygenation. So across the range of patients, these were the average changes from the baseline, before and after. But as I said earlier, patients are individuals, they're not averages. So when you look at individuals, that's where the problem comes. So when you hyperventilate a patient, when you drop the CO2, because you're reducing cerebral blood flow and blood volume, these are the changes that you'll typically have. Because you're reducing cerebral blood volume, the intracranial pressure comes down. This is the start of the test. This is the end of the test. And so therefore, you also see a change in perfusion. The problem is that it doesn't always happen like that. So this is another patient where, despite the fact that you're hyperventilating a patient and you're reducing cerebral vascular diameter, you have an increase in perfusion. And people very often get confused about this. It is a little bit more complicated, and maybe we can chat about it a little bit later. The principle here is that sometimes when the intracranial pressure starts high, and then when you hyperventilate patients, even though you are vasoconstricting, this is my theory anyway, even though you're vasoconstricting, because you're reducing cerebral blood volume and therefore intracranial pressure, the reduction in intracranial pressure very often will lead to an increase in microvascular perfusion, despite the fact that you're vasoconstricting, because you're reducing cerebral blood volume and intracranial pressure. But that only works when the intracranial pressure is high. So typically you would see this. This is the reverse of it. Here the CO2 goes up and the intracranial pressure goes up. But even though the CO2 is causing increased vascular diameter, you have a drop in brain oxygenation because it's the indirect effect of the increase in intracranial pressure. So very often we'll see this. If you continue to raise the CO2, the intracranial pressure will go up because you are vasodilating. And as you're vasodilating, you're increasing cerebral blood volume and therefore intracranial pressure. And that's why it goes up. Brain oxygenation goes up initially also because you're vasodilating and you're increasing cerebral perfusion, but only to a point. And that point is the point at which intracranial pressure then becomes an impediment to perfusion at a microvascular level. And then the brain oxygenation goes down. And you'll just see that time and time again. If you increase the intracranial pressure within a relatively low limit of intracranial pressure, what you expect with perfusion to the brain is exactly what you get. You get increased perfusion of the brain. But once the intracranial pressure becomes a problem, then even though you're vasodilating, you very often have a change in the relationship between the increased CO2 and the perfusion in the brain. And so that can become a little bit complicated. I think that the take-home message is be very careful. If you don't have monitoring of perfusion in the brain, be very careful about acute changes in CO2 because you can't always predict what impact that has on perfusion of the brain. Example 2, this is about pressure autoregulation. So blood pressure and intracranial pressure have a really important relationship with each other, and it's largely governed by this concept called pressure autoregulation or pressure reactivity. And what that means is that blood vessels in the brain have relationship with changes in blood pressure. So typically what happens in normal physiology is as the blood pressure goes up, within a particular range, usually this is between 40 and 50 millimeters of mercury to about 150 millimeters of mercury. Pressure regulation means that the blood vessels at an arteriolar level decrease in size in response to increased blood pressure. So you have higher blood pressure, but narrower vascular diameter, and that's why you have this plateau. So between that range of blood pressures, cerebral blood flow remains relatively, not absolutely, but relatively constant. Below that range and above that range, blood pressure has a passive relationship and a passive proportional relationship with cerebral blood flow. The problem is that autoregulation is not always intact. And so depending on the pathology, if you have an insult to the brain, whether it's traumatic or meningitic, autoregulation may be impaired. And then on the far end of the extreme, the blood vessels have no capacity to autoregulate, which means that their vascular diameter completely and passively depends on changes in blood pressure. So as the blood pressure goes up, cerebral blood volume goes down. As blood pressure comes down, cerebral blood volume comes down, and cerebral blood flow comes down. And cerebral blood volume, of course, determines intracranial pressure. So the problem is that pressure reactivity capacity varies between patients, and sometimes in a single patient on different days. And so practically, this is what it means. This is a patient with intact autoregulation. So here, you're increasing the blood pressure. And if you remember the graph, the normal response is decreased vascular diameter of those arterioles. As you decrease the vascular diameter, you also decrease cerebral blood volume. And because you're reducing cerebral blood volume, you reduce intracranial pressure. So that's what happens when autoregulation is intact. When autoregulation is impaired, the exact opposite happens. Now, there's no ability of the vascular bed to react actively. So all that blood pressure is passively passed on to changes in cerebral blood volume. So there, as you increase blood pressure, you increase cerebral blood volume and therefore intracranial pressure. There's no ability of that vascular bed to react actively. So PRX is a measure, for instance, of autoregulation. So PRX is a measure that was developed by the guys at Cambridge. And all that is, it's called the pressure reactivity index. All that is a correlation coefficient between blood pressure and intracranial pressure. So intracranial pressure is now a proxy of cerebral blood volume. So if you've got a correlation coefficient and a moving one, so it's constantly calculates a correlation coefficient in kind of a moving 20-minute interval, then you can get an idea of what autoregulation is passively. So if there's a very high correlation coefficient, so changes in blood pressure mimic changes in intracranial pressure, then it probably means that autoregulation is impaired or non-existent. Because if autoregulation is intact, you shouldn't have a correlation between blood pressure and intracranial pressure. So if blood pressure and intracranial pressure are doing this, they correlate very highly, which means that there's no pressure reactivity, means that autoregulation is impaired. And we don't know too much about that pressure reactivity in children. These are the studies that have been done. You can see that all the studies are relatively small numbers, but we completed a study just recently, and we're writing this up at the moment. So it's 196 kids with severe TBI and PRX. And I'll just take you through it very quickly. I'll just, in fact, skip that and just show you that PRX, that pressure reactivity index, is as good as intracranial pressure as a predictor of both mortality as well as functional outcome. So it also seems to be independent of level of consciousness. So it's not just a proxy of a more severely injured brain. And that probably makes sense because whether autoregulation is intact or impaired has a really strong impact on what happens when we manipulate blood pressure. So again, we can try to do the right thing by increasing blood pressure or decreasing blood pressure because we're chasing a perfusion pressure, for instance. But if we don't know what the autoregulatory capacity in the brain is, we've got no idea of what those changes to blood pressure, or what impact those changes to blood pressure have on perfusion of the brain. So both in statistical and practical terms, the status of autoregulation has a major impact on what happens in the brain when you manipulate blood pressure. And the problem is that very few of us monitor or even try to determine what autoregulatory capacity is. And that's one of the reasons that I believe that this idea that a single perfusion pressure can be applied to every patient without recognition of what the autoregulatory capacity is doesn't make any scientific or physiological sense. So I'm going to hurry up a little bit here, and just very briefly, I'm going to run through the other things that we do. We monitor brain tissue oxygen, so we've got quite a bit of experience with that, and we've published that. And this is probably, this is from several years ago, but it's a really illustrative graph because these were time-linked measures of brain oxygenation and intracranial pressure across a range of patients. Now, if you had a simple and predictable relationship between intracranial pressure and perfusion of the brain, you should have a relatively linear and relatively good correlation between the two. And you just don't have that at all. It's statistically significant, probably because there are just thousands of data points here. But as you can see, and you don't have to be a stats expert to recognize that this is just a big cluster. There's no one relationship here. And even if you control for individual patients, so you just plotted the intracranial pressure and brain and time-linked brain oxygenation, or in fact, time-linked perfusion, any other perfusion measure, you get the same thing. There's no one relationship between intracranial pressure and perfusion of the brain, even in individual patients. So brain oxygenation, you can use it to interrogate perfusion pressure thresholds for cerebral perfusion pressure. Typically in children, it starts to drop off under 40, but again, these are averages, not individuals. We've looked at it in association with outcome. We've looked at it in association with a measure of metabolic stress. So with microdialysis, we use the lactate pyruvate ratio as a measure of the balance between aerobic metabolism and anaerobic metabolism. Under 20 millimeters of mercury, but really under 10 millimeters of mercury of brain oxygenation. That's really where you see the lactate pyruvate ratio start going up. This is just another way of showing the same thing. These are receiver operating characteristic curves for brain oxygenation and the lactate pyruvate ratio under a brain oxygenation threshold of 20, 15, and 10. And you can see at 10, that's really when that receiver operating characteristic curve starts looking very, very good in terms of the balance between the sensitivity and specificity of that threshold. This is just to say, show that it's real. These are patients. I got 2 patients who had a brain oxygenation catheter in, who had a cardiac arrest while we were monitoring their brain oxygenation. Both of them had respiratory arrests. And this was the best case scenario. So there was an intensivist by the bedside, but you can see both in this patient and the next patient that despite really good CPR, the brain oxygenation was just absolutely zero. This you can see it trends down to zero because the oxygen is still being used, even though there's no perfusion. But when it gets down to zero, it's just flat. And then very quickly, we also use microdialysis, and that gives us an insight into brain chemistry. I'm going to skip over this for interest of time. We use continuous electrophysiology, and that gives us a window into some of these repetitive changes that we see in intracranial pressure and brain oxygenation that may reflect subclinical seizures. And those are really important because it has adverse effects for metabolism, but you've got no idea that the patient's having subclinical seizures. And subclinical seizures are probably much more common than actual clinical seizures in patients with any form of acute brain injury, whether it's trauma, whether it's meningitis, anything that lands a patient in coma. Subclinical seizures are a lot more common than we think and are potentially harmful. So sorry to rush it last a little bit, but the take-home messages, and I want to leave some time for questions, is that intracranial pressure is really complex, and it's complex in different pathophysiological conditions, all of which may be quite different from each other. The impact of absolute intracranial pressure and the changes in intracranial pressure depends on 2 things, both the underlying condition as well as the underlying physiology. An important principle is that the individual is not the average. So we'll get average values for the association between intracranial pressure and outcome, or the association between intracranial pressure and perfusion of the brain. or averages for the relationship between CO2 and intracranial pressure. But those are just averages. It doesn't necessarily mean that your patient is going to react in the same way. And then very lastly, I hope if I haven't made any other point, then I hope I've made this point, that when you're thinking about intracranial pressure, you have to think a little bit more deeply about it than just a number. So I don't think that our current guidelines, and whether they be applied to traumatic brain injury or stroke or meningitis or hydrocephalus, about intracranial pressure are good enough, because intracranial pressure is far more complicated than that. It's a good starting place, and if you've got nothing other than that, I think those represent a very good starting place. But if we're going to go beyond that, and we're going to be a little bit more detailed and a little bit more focused about how we understand intracranial pressure, so that we can maximally benefit the patient and minimize the harm that our iatrogenic treatments and interventions may have on patients, then I think we need to understand a little bit more about intracranial pressure than we currently do. And at that, I'll leave it, and I hope that we have at least a little bit of time for questions. Thank you.
Thank you, Tony. That was an amazing talk, as always. And before I ask any questions myself, I'm going to get Dr. Gopal Achari. Gopal is a very senior neurosurgeon in Calcutta who works amongst other places in Park Clinic, and who has a special interest in intracranial pressure monitoring, and does much more of it than I do or I have ever done. So Gopal, we'll get you in, and maybe you want to ask some questions or clarify some issues with Tony.
Yes, good evening. Very interesting talk, actually. And
Gopal, you need to come closer to the microphone. We can't hear you.
Good evening. Can you hear me now?
Yeah, better.
Yes. It was a wonderful talk, actually. So I'm one who strongly believes in using intracranial pressure monitoring for treatment of head injury, and I've been using it for last decade, except for last 2-3 years when I'm not getting enough trauma patients right now. But what in India, what we were trying to do is, as you said, we're trying to look at numbers. We are trying to look at numbers, treat them by a simplified method of using a strain gauge catheter. But I'm glad you emphasize that in case of monitoring head injury, it means more monitoring, not to do away with the intracranial pressure monitoring. I have unfortunately failed to sort of inspire my juniors or to address people around me to use more monitoring. Somehow, the main problem we get stuck with is a cost. And again, they say that it's just a number, so we can manage by looking at CT scans. So that has been one drawback, and I always feel that we are being being compromised by not having so many gadgets. But a couple of questions here. I just keep in touch with the recent advances. I was just going through an article in the Frontiers in Neurosurgery, the recent article which came out in 21, one which said that there is a scope of a blood lactate. It says that if the blood lactate is high, it can act as a very potent vasodilator, and you should keep your blood lactate level low. And the pressure reactivity index, of course, you can divide the pressure reactivity index, use the pressure reactivity index, and find the optimal CPP, it's known as CPP opt. And you can actually divide the categories into the pressure passive individuals and pressure active individuals, and use whether to use it for ICP control and cerebral pressure monitoring. And the third aspect, you spoke about permissive hypocapnia for controlling the intracranial pressure, but you don't seem to be using the SGVO2 or the jugular venous pressure oxygenation. So your take on these questions. So I just thought whether I should put it up for you.
Yeah, great. Thank you. So those are all really good questions, and there are several of them. And we could probably talk. We could probably have a conversation about them for the next hour. So I'll just kind of very brief respond to a couple of things that you picked up on. So one of them is convincing our colleagues about monitoring. I think that's a real challenge. I think for a couple of reasons. One is cost, as you say, particularly for those of us from low or middle income countries, costs are really important. So the way that I've got around that is doing an economic analysis and looking at the first thing one has to demonstrate that the monitoring that you do, and it's not just about individual monitoring, it's a whole package, right? So when I think about our patients, people often ask me, if you had one monitor, which one would that be? I try to resist that where possible, because the various monitors that we have give us a particular insight, but none of them gives us the whole picture. And so one of the things that I find most useful is to try to, in an individual patient, to put all the information together and try to figure out what's happening in that particular patient with all the physiology. But of course, there is a cost involved. And when I'm motivated to our administration, so firstly, our administration doesn't cover all of our costs. So some of our costs are hospital administration covers. Some of the costs will cover through kind of various research grants. So that's the only way that I've found around it. But if you do the economic analysis, and if you can demonstrate that your intensive care or neurocritical care approach really makes a difference to outcomes, A, that it reduces mortality, but B, even more important for administrators, that it reduces morbidity, then you can create an economic argument looking at the economic costs of saving a patient from severe disability to mild disability. Because the economic cost to the society of a patient with severe disability, when you play that out over 20 or 30 or 40 years, are substantial. And if you do that proper economic analysis, then the expense in the beginning, if you can reduce that morbidity, is well worth it. But it's a complex argument, and you need to have that long-term view, and you need to convince your administrators that that long-term view is worthwhile. And as you know, and I'm sure your hospitals are quite similar to ours, our administrators are like politicians. They don't have a long-term view. They've got a short-term view, which means they want to come in budget with their financial year. So so it can be complicated, but that's how I've approached it. And then to address the concerns about our colleagues that you can just look at the CT scan. So firstly, that it's completely false. So one of the things that we've looked at over the years is how well you can predict intracranial pressure from just looking at the CT scan. And the take-home message is that whether it's traumatic brain injury or whether it's hydrocephalus, you can't. That the correlation between a senior clinician's estimation of intracranial pressure, whether high or low, and what the scan looks like is really, really poor. So sometimes it's obvious, you see a patient with a massively swollen brain and midline shift. Of course, the intracranial pressure is going to be high. But those are extreme cases. And what we found is that looking at just because the cisterns are open and just because there's no midline shift doesn't mean the intracranial pressure is not elevated. So scientifically, I can confidently say that the prediction of intracranial pressure based on the CT scan is really, really poor. And then the second problem with that is looking at the CT scan only tells you what's happening at that point. It doesn't tell you what's going to happen an hour later. And you can't scan a patient every hour. And one of the things that everybody knows about traumatic brain injury is that intracranial pressure is incredibly dynamic. Just because the pressure is normal now doesn't mean that in 10 minutes it's still going to be normal. So I think the idea of looking at a CT scan and trying to predict not only what the intracranial pressure is at that point, but what the intracranial pressure is going to be in a half an hour is completely unscientific. So that's the issue of CT scans. And then, of course, the common argument that they have is, well, the Randy Chesnut's trial in South America showed that intracranial pressure monitoring wasn't particularly useful. And my problem with that trial, and I think Randy's problem with that trial as well, even as the guy who did the trial, was that these were centers that weren't geared for neurointensive care. And they never used intracranial pressure monitoring before. And if you don't have a very clear plan for how you're going to manage intracranial pressure, then sometimes at best it may be useless. At worst, it may be in fact harmful. And if you're going to respond to, for example, if somebody has increased intracranial pressure because of subclinical seizures, they need treatment of the subclinical seizures. They don't need a decompressive craniectomy. But if you've got a protocol that just says you've got a stepwise approach to treating intracranial pressure, and that's where your thinking ends, then I think intracranial pressure monitoring may not be useful at all. In terms of the blood lactate, we haven't looked at blood lactate. Certainly no brain. The way that the brain manages lactate is a little bit complicated because there's also the lactate shuttle. So the brain can use lactate as a fuel. So that's why we like to look at the relationship between lactate and pyruvate as a more sensitive marker than just absolute values of lactate. I suspect the relationship between blood lactate and overall brain health probably relates to the overall connection between polytrauma and traumatic brain injury. That if your blood lactate is high, you're probably badly resuscitated, and there's a lot more going on in terms of the inflammation and a systemic injury. And then lastly on CPP opt. So I think having PRX is is very useful to know what the status of autoregulation is. I'm a little bit more cautious about the idea of CPP opt for a couple of reasons. So for the others who might not know, just to summarize, CPP opt is the idea that you can optimally identify a perfusion pressure, which is the best perfusion pressure for that particular patient. And that's both, in my view, that's both right and wrong. So it's right in the sense that you can identify a perfusion pressure, which is the perfusion pressure at which PRX is maximal. So you get maximal vasoconstriction for a particular blood pressure, which if that is the case, then you have the maximal reduction in vascular diameter and therefore cerebral blood volume and therefore intracranial pressure. So if you look at the curve for PRX and for perfusion, you get a U-shaped curve. So the PRX it's the inverse. So a low PRX is good, a high PRX is bad. So the point at which PRX is lowest, that perfusion pressure, is said to be the optimal perfusion pressure. And that is true in terms of its mechanical aspects, in terms of cerebral blood volume. My concern is that when you work out a CPP opt, that perfusion pressure tends to be quite high and a lot higher usually than the brain needs for perfusion. So you're maximizing the mechanical benefit of low cerebral blood volume, but potentially you're pushing patients to a higher perfusion pressure. So typically that CPP opt would be in the region of 90, 95, even 100 millimeters of mercury. The problem with that is if you chase that perfusion pressure, then you have all the downside of aggressive fluid management. So inotropes and excess fluid management. And there was a randomized trial in 1999 run by Claudia Robertson that showed you can do that, but the risk of ARDS is 5 times higher when you try to chase those high perfusion pressures. So I think the adverse effects of that strategy are overwhelm the benefits. So I like to know what the CPP opt is, but I don't chase it. I still chase the minimum cerebral perfusion pressure that will just give me confidence that perfusion is maximized. Not necessarily maximized, is above the minimal strategy. And then in terms of CO2, we monitor end-tidal CO2. Your question specifically about CO2, just remind me again.
Just asking about the jugular venous saturation extraction. You're not using
so I don't look at we don't use jugular venous extraction. There are very few places that still use it because it's been well shown that it gives you some good indices, but only 50% of the time. And that other 50% is when the catheter is up against the the vessel wall, or there's a little bit of microthrombus, or the patient's head is turned. And then, so I'm not that interested in the extraction. I'm just interested in the relationship that changes in CO2 have with intracranial pressure,
yes, sir,
and with brain perfusion, brain oxygenation. And again, it's not the absolute brain oxygenation; it's the change. So the question for me is, if you raise the CO2 from 4 to 4.5 kPa, what effect does that have on intracranial pressure, and what effect does that have on brain oxygenation? And that you see immediately. So I'm happy with the combination of those two.
Any other clarifications from Gopal, or any other comments?
Yes,
Dr. Acharya?
a lot of questions actually. If you have time, I'd like to ask. He spoke about subclinical seizures.
Yeah.
And there's a concept using a depth ECG electrode and for detecting depth seizures. Do you have any comments on that?
Yeah, so I think that's a great idea. We've just never done it. And so there are a couple of things about seizures. So for me, there are clinical seizures, so that's obvious. There are subclinical seizures, which are a little less obvious. And if you've got good continuous EEG, and it has to be well managed as well, because the problem with continuous EEG is that you always have a little bit of drifting impedance with the electrodes, so you have to have somebody adjusting the electrodes all the time. That's, of course, better than just looking at a patient having seizures. But then having intracranial pressure at least intracranial seizure monitoring would be the best. And then you have two options, either a strip electrode or a depth electrode. We don't have any experience of that. There are a few places in adults that have quite a bit of experience with strip electrodes and depth electrodes. And the advantage of those, and those are usually when patients have needed a craniotomy, because then it's easy to justify. You do a craniotomy, you just leave a couple of strip electrodes behind. The advantage of that is that you can get not only continuous EEG, but you can pick up potentially cortical spreading depressions. And cortical spreading depression or cortical spreading depolarization also seems to have adverse effects. And for those who don't know about cortical spreading depression, these are waves of mass depolarization that occur around a focus. And so that focus can be a stroke, or it can be a contusion, but you have these waves of mass depolarization that circle a lesion. Depending on the size of the lesion, it comes around every 20 minutes or every hour or so. And every time that wave comes by, you can see these massive derangements in perfusion of the brain and chemistry. And again, these are all these incredibly interesting physiological things that are happening beneath the surface of the brain that we've just got no idea about. And I suspect that in the same way that there were things that were happening inside the brain that we had no idea before we had CT scans and MRI scans and now intracranial physiology, probably in 20, 30 years' time, we'll have a much deeper understanding of what these things mean and how to treat them. But that would be the benefits of subdural strips or depth electrodes. There's a colleague of mine I was just chatting to last week, Dave Adelson from the US, and they've got some experience with depth electrodes, not only for the epilepsy patients, of course, but also for patients with traumatic brain injury. But it's only a handful of patients. So I'm very keen to try it. I just don't have any experience with it yet.
Maybe we should get Dr. Amitabh Das in. Amitabh, you have some questions you wanted to ask.
Nice presentation. Thank you. And I just want to ask, what your experience about syndromic children? Do you use Icp monitoring in syndromic patients?
Yeah, absolutely. And I think most people's sometimes with the complex syndromic patients, we know that their association with intracranial pressure is usually quite high. But then there's a clinical indication to operate on them anyway. So they're kind of the complex cruisons, and obviously the Pfeiffer syndromes and all that. We know those are problematic cases, but we're going to operate on them anyway. And in most of those, they settle down. In some of them, they remain complicated and associated with raised intracranial pressure for several different reasons. So some of them have hydrocephalus, and that's easy. You can manage that. But very often, I mean, as I'm sure you'd have experience with, they've got complex craniosynostosis, and that very often involves the skull base, and therefore they have venous hypertension because the skull base hasn't developed properly, and your jugular venous drainage, the foramina are relatively small. And those are the really difficult ones, trying to manage those. And then there are all sorts of things that one can do, trying to have more complicated posterior distractions and posterior fossa opening up, but then the morbidity starts to increase. For the more simple craniosynostosis like trigonocephaly or scaphocephaly, they're much lower incidence of intracranial pressure, but some of them do have raised intracranial pressure, or at least chronic raised intracranial pressure. Sometimes you do an MRI on them and they've got some tonsillar herniation as well. So occasionally when we get older kids, it's easy in young kids, you've got a clinical indication to operate and you do that. And sometimes the kids come to us when they're a little bit older, and they've got sagittal synostosis, but they've got headache. And maybe they got some copper beating. We've had a couple of patients who presented late to us with visual deterioration. And so for those patients, very often, you're not going to get a great cosmetic effect because the brain is pretty solid, at least the skull's pretty solid by then. And then just trying to identify which of those patients have symptoms due to raised intracranial pressure is worthwhile monitoring them. So typically we put in an Icp monitor and watch them for a couple of days. And then it's very useful having a continuous record, because very often during the day their intracranial pressure is fine. And then at night when they sleep and they have a relative rise in CO2, you start seeing the plateau waves in intracranial pressure.
In fact, I have seen two such patients, syndromic patients, in whom the ICP, when we put in the ICP catheter, the ICP came out to be very sky high. One of them had even 63 millimeter of mercury.
Yeah, it's incredible.
We immediately put him for surgery. And
so that's the incredible thing about intracranial pressure, right? You have, depending on the pathology, craniosynostosis patient with venous hypertension, a patient with pseudotumor cerebri. They got pressures of 60 and they're sitting there talking to you. It's incredible.
Exactly. And the other thing I want to ask is about monitoring pediatric head injuries. Because there are very little data on pediatric head injury, pediatric ICP monitoring in pediatric head injuries. In fact, from India, I have found two papers, one from our institute, which was published in 2016, and one in 2019 from All India Institute. And both of them were retrospective studies, and they suggested that pediatric ICP monitoring is productive for treating head injury patients. So what your suggestion or what your experience?
Yeah, so it's hard to develop good data outside of a randomized trial. And the problem with randomized trials is that that to treat intracranial pressure properly, I think you really need a system in place, kind of really good protocols and very well thought out. What are you going to do when intracranial pressure is 25? And for me, it's complicated because it's not just about what you're going to do. It's about why is the intracranial pressure 25, and what consequences are there of an intracranial pressure of 25. So I routinely monitor all our patients. Sorry, I'm just quite conscious of the time. I just see I'm most embarrassed that I'm supposed to join another meeting. So I'm going to have to exit. Sandeep, I'm so sorry. I was just so enjoying talking here that I've just gone over.
No problem at all. We thoroughly enjoyed it, and we never realized that the time was over.
Yeah, no, I'm terribly sorry.
And the time is not over. I mean, don't worry about that at all. Amitabh, have you anything else to say or ask?
Regarding the cost of using ICP monitoring in our country, actually, we have developed a policy to reuse the catheter so that it cuts down the cost. And sometimes we can use some non-invasive measures as well, like monitoring the diameter, optic nerves with diameter, which we can use for these patients when the cost is a very difficult issue in our country. So that's it. I just want to say that only.
Yeah, I mean, there are just so many great things that I'd love to talk about. We probably could go for another couple of hours, but I'm so embarrassed. I'm already late for another meeting. Sorry about that, Sandeep. So,
any other thoughts? Can I just ask a very stupid, simple question? Yeah. If you had a choice between monitoring a patient with a diffuse axonal injury with ICP monitoring, microdialysis, electrophysiological monitoring, which one of the three would you choose? Or do you think, like intraoperative neurophysiology, which is another forte of yours, we need to do combined monitoring to get any results? That's the first bit. And another stupid question I have is, one of the things I find about intracranial pressure monitoring studies is that...
I think he's joined us now. Tony, we were just discussing whether there are any therapies in Italy.
Can we have the little mute, please? So I was just going to ask you that what are the problems with the ICP pressure? Sorry?
I would have it all. I'd take it all.
No, I'm not going to say that. I'm going to say ICP studies, the studies that come out showing ICP monitoring makes a difference in terms of at least early mortality, problems, etc. In our experience, we found we tend to monitor patients that we think will do well and not waste monitoring on patients who we think are going to be a disaster. So do you not think that the outcome measures that we use actually are a little biased because we monitor patients that we think will do well, and we don't monitor patients that we think will have a disastrous outcome?
Yeah, so that's the problem with intraoperative neurophysiology. Monitoring patients with brainstem tumors, it's the selection criteria. So that can go both ways, So patients who look well or whose scan doesn't look bad, we tend not to put in ICP monitors. And we tend to reserve the ICP monitors for patients who are salvageable but with really severe injuries. So, you introduce bias both ways, unfortunately. So you can only do a randomized controlled trial, but it's going to be very, very difficult ethically to run that.
What about the question about which modality of monitoring, if you had one choice, microdialysis, ICP monitoring?
I'd probably still go with intracranial pressure monitoring. But I'm like more is more, not less is more, more is more.
What about your opinion of an ideal ICP monitoring? What is the ideal? Which is the ideal ICP monitor?
It's the typical Cogman monitor. It's the only real one on the market at the moment.
And what's your impression?
I need to run now.
We'll just wind it up. We've exceeded our time. One last question. What is your opinion about this optic nerve sheath diameter?
I think like many other non-invasive monitors, it has a place, but it doesn't give you an absolute intracranial pressure. So my personal view is that it's very good for patients with like either screening patients or patients with hydrocephalus, where you're looking at the same patient, but looking at a change over time. I think those relative changes, I think, are very useful. But like with most non-invasives, if you look at its correlation with actual measured ICP, there's definitely a correlation, there's no doubt. But it's not sensitive and specific enough to say the ICP is 10 or the ICP is 20. And the problem with ICP, of course, is you need a continuous measure, because the ICP can be 10 now, you turn your back and you look again and the ICP is 20. So that's the problem. Really good screening tool, a good tool to look at one patient over time, but those are the limitations.
Fantastic.
So unfortunately,
Thank you very much.
Sandeep, thank you so much.
Thank you. And I'll just hand over to Kaushik to say the formal thanks.
Thanks.
Thank you, Dr. Figazi, for your time. And we thoroughly enjoyed your talk. And I also thank all the panelists, Dr. Das, Dr. Acharya, and Professor Chatterjee. Thank you all. Our next talk will be on 2nd of September, on Thursday, probably at 4 p.m. We'll try to prepone it at around 4 p.m. And topic will be on fluid and electrolyte disturbance and the management of the same as pertaining to neurosurgery. Speaker will be Dr. Shubhas Todi. I now hand over to Deepak for the conclusion.
Yeah, thank you very much. I would like to thank on behalf of HealthNU our speaker, Dr. Tony Figazi, and he made a very valid point that intracranial pressure is not just the number, and it is more than that. I would also like to thank Professor Sandeep Chatterjee, who conceptualized this basic in neurosciences webinar, the whole series. And I would like to thank Dr. Kaushik Seal for coordinating this session extremely well, and our panelist who has added value with their own insights and questions, Dr. Gopal Acharya and Dr. Amitabha Das. I would like to thank all our audience who came in great numbers in spite of this Thursday busy schedule and late in the evening. 132 doctors have joined us for this webinar. This basic in neurosciences webinar is becoming a great success, and we have always had more than 120-25 doctors joining us on every alternate Thursday. So on behalf of HealthNU, I would like to thank all the audience for making it possible to make this webinar a success. Thank you very much. Good night to you.